2023, about 24 million people in the US reported using benzodiazepines, and roughly 20 million of them use them as prescribed. That's a lot of people just in the US. In 2018, 50% of patients dispensed an oral diazepine received for 2 months or longer, a duration where dependency risk starts to arise. And today, I'm especially interested in exploring not just the biology of tapering logistics, but the systemic obstacles, fragmented care, insurance gaps, the stigma that comes with it, regulatory pressures, all of these things that hinder safe and equitable management. So to open us up, here's a sobering statistic. So a 2025 Joint Clinical Practice Guidelines now recommends that tapering schedules should begin with 5 to 10% dose reductions every 2 to 4 weeks and avoid reductions greater than 25% every 2 weeks. And this literally reflects the delicate balance that you need when you're trying to taper. It's very important to assess what this clinical guideline is recommending. It's recommending that we taper slowly and it's individualized, literally a strong caution against rapidly cutting people down, avoiding reductions that are so great that people are all of a sudden having these withdrawals, because those withdrawals can be tough for people. Hello, and welcome to the Transformed Minds. This is the podcast where we explore the real-world intersection of mental health, addiction, and transformative care. I'm your host, Dr. O, and with each episode, we take a very thoughtful and practical, evidence-informed look at how we improve psychiatric and addiction care, from clinical settings to community spaces. If you're new, here's the vibe. Host RX is just me and you breaking down the research and sharing what actually matters for our work. With Expert RX, we bring in brilliant minds from all over the field of addiction and psychiatric care. It could be clinicians, researchers, change makers, and we also have our lived experts where the real life stories come in, guests who have lived it, they've survived it, and they are reshaping our system because of it. Today, our episode is going to be a Host RX. It's just me and you. And we're going to talk a little bit about benzo use disorder. And I am so glad you're tuning in, okay? So benzodiazepines, we know alprazolam, lorazepam, klonopin, there's a whole lot of them. They can be lifesavers and acute stressors. But long-term, they carry real life risk. It could be cognitive dysfunction, making people more prone to falls, physical dependence. All of these things makes it really difficult, especially when you're trying to stop it. In 2023, about 24 million people in the US reported using benzodiazepines, and roughly 20 million of them use them as prescribed. That's a lot of people just in the US. In 2018, 50% of patients dispensed an oral diazepine received for 2 months or longer, a duration where dependency risk starts to arise. So we know long-term prescribing is common among older adults. I have multiple patients that are over 60 that are on benzos because they've been taking it for over 20 years. And generally it's recommended to stop giving benzos after a certain age, and it can be so difficult to taper people off of it. Over the recent years, benzodiazepine medications, alprazolam, which is Xanax, clonazepam, klonopin, diazepam, Valium, Librium, all those things are there, right? Over the years, we've seen them prescribed for a lot of different things, including anxiety, insomnia, and yes, many clinicians, policymakers, and patients struggle with how to safely taper it, right? How to safely manage the withdrawals, how to navigate the health system in which dependence and misuse can coexist, whilst it also helping people, right? And today, I'm especially interested in exploring not just the biology of tapering logistics, but the systemic obstacles, fragmented care, insurance gaps, the stigma that comes with it, regulatory pressures, all of these things that hinder safe and equitable management. So to open us up, here's a sobering statistic. So a 2025 Joint Clinical Practice Guidelines now recommends that tapering schedules should begin with 5 to 10% dose reductions every 2 to 4 weeks and avoid reductions greater than 25% every 2 weeks. And this literally reflects the delicate balance that you need when you're trying to taper and take people off. It's very important to assess what this clinical guideline is recommending. It's recommending that we taper slowly and it's individualized. And it's literally a strong caution against rapidly cutting people down, avoiding reductions that are so great that people are all of a sudden having these withdrawals, because those withdrawals can be tough for people, right? Today, I'm going to give you a little bit of a roadmap of what we're going to go through. We're going to summarize what the literature says. We're going to walk through a little bit of the clinical pitfalls, map some of the systemic level barriers, and apply it all in a case of how we would manage a case that may come to us. And we will end with some concrete takeaways for clinicians, trainees, policymakers, the general public, and we'll integrate all of this into a tapering benzo medication guide, which is available on the ASAM website, AAAP website. We know a lot of us are not reading the journals. We're not reading the guidelines. So this is a way for you to get that information in a summary. But if you want the full clinical step-by-step, all of that, please go read those guidelines. Please read the journals. It's going to be helpful for you. All right. So let's get into it. And we're going to start off with some terms and definitions. We know physical dependence and tolerance, they're expected phenomena when you're dealing with benzo use. But there's a distinction between them, and then there's an overlap with benzo use disorder or substance use disorder. So with physical dependence, we know it's a biological phenomenon. It develops in response to repeated use of the medication. In the case of benzos, it's basically when there's a downregulation of that benzo receptors and you adapt to it. Your body, physiologically, you adapt to that receptor, right? And when the physical dependence, it is an expected consequence of ongoing use of benzo. So if you're using benzo 1 week, 2 weeks, 3 weeks, 4 weeks, by 2 months, it's expected that you're going to have some physical dependence. That's literally where we see the most risk arise at that 2-month mark, which is why a lot of the standard practice guidelines is to give these medications for acute short-term use only, whilst for some people, they are on that long-term medication like an SSRI or an anxiolytic that can help them with minimal risk long-term, but some of them take a long time to start to work. SSRIs, they take 6 to 8 weeks to kick in. So while someone can't, if someone is having severe anxiety, or for the people that may use it for insomnia, they're having difficult sleeping that's affecting their entire life, they cannot wait 6 to 8 weeks for medication to kick in. So during this short-term period, we can use benzos to help. The problem becomes when it becomes long-term use. And even the practice guidelines have found, like, there are that one-off cases, benzo use, like in very severe anxiety where it's like treatment resistant and nothing is working. In some cases, you may need to use benzos, but we have to be very cautious, right? We have to be very cautious. On the other end of this, substance use disorder is a chronic disease that's associated with the functional change of the brain circuits that mediate like your stress, decision-making, behavior reinforcement, all of that. If we think about substance use and the reward pathway, that whole entire system, the ventral tegmental area, all of those brain circuits are getting affected. And it's literally mediating your stress, behavioral reinforcement, and decision-making capabilities. And we see that with substance use when you see impairment of decision makings, impairment of your insight, right? We see all of these things. So you can see the distinction between substance use disorders and physical dependence. Dependence is part of the criteria for substance use disorders to be diagnosed. If you look at the DSM that criteria, or even the ICD criteria, dependence is there, right? It's one of the criteria for substance use disorders. And most of the time it includes, like I've mentioned again, impaired control, overuse of the substance, and continued use despite the consequences, right? So people that are still using, like when I'm using substances I can't wake up to go to work because I drank too much last night. I woke up this morning and I was hungover and I couldn't really go to work. That's impairing your function to go to work. Or when I'm intoxicated, I get so annoyed and irritable that I start arguing with all my families, my kids and my spouse or my partner. They left me because I was drinking too much. You've impaired your social functioning, right? Or I can't really focus in school. I'm doing bad in school because I've misused substance to the point where it's causing me some significant impairment. I've been using benzos for so long. I've developed a physical dependence. I'm having withdrawal symptoms when I'm trying to come off of it. It's making me feel sedated. I fell and hit my head because it can cause falls. Or now I'm forgetting a lot of things because I've been using for 20 years. So all of these things are significant impairment that can happen. And for some people, by knowing all of these consequences that can happen, they still continue to use. That's when you're like, okay, there's a use disorder. And one of the things I love to share with people and educate people about, talk about, just have a discussion is that substance use, it's not really only behavioral. There's so many different aspects of it. And I think for so long, a lot of the stigma when it comes to substance use disorders is the fact and the idea that this is behavior. And if people wanted to stop, they can stop it. So, a quick crash course about the biopsychosocial parts of substance use. For some people, genetics play a role, your psychosocials play a role, your environment play a role. So, I give this example of think about a society or community where the drinking age is about, and this is all like scenarios now. Think about it. It's a norm to start drinking at a young age. What happens is people start to, as they're growing up, they're going to have this understanding that drinking is okay. It's okay if I drink. There's nothing wrong with drinking. And then once they start drinking, think about what we just talked about, the reward, that pathway system, right? That whole genetics, biological part of it. If there's someone in your family that's drinking or uses a specific substance, with drinking, studies have shown that if you have a relative that drinks, you're more likely to drink compared to someone that didn't have a relative that was drinking. So genetics play a role. There's some specific population that they are either slow metabolizers or ultra metabolizers of substances because of where they're from, because of the country they're from. A lot of like Asian countries may have different metabolizers. When we look at alcohol, like female versus male, the way that we metabolize alcohol is very different because of the water component of our bodies, right? The fat components of our bodies. So we metabolize alcohol differently. So this is where that genetics come in. So it's not just, oh, if the person wanted to stop drinking, they could stop drinking. There's that genetic aspect. There's that biological aspect. And then there's environment. If I grew up in a place where I saw everyone smoking, I'm more likely to smoke than not, right? Because it's a norm. It's okay. Everyone is doing it, right? So we have to think about this. Think about a child that grew up in a house where they're sent to go buy a beer starting at the age of 6. Inherently, they're going to start believing it's okay. I can do it too. And they're probably most likely going to start doing it at a young age. And if you think about how the brain works and develops, even at the age 26, your brain is still developing, right? That's when we start completing that like development of the brain and it's like matured. So if you're starting at an earlier age from 6, 7, 8, 13, 14, all of that, you're changing the chemistry of your brain. Like those brain circuits that we talked about, you're changing them. Like you're altering how they are, how they're going to see things, how they're going to relate to things. You're changing that reward pathway and you're going to start going in that cycle of, oh, took it, feeling good, not taking it. I need a little bit more. Then you do that and you feel that again, because then you come off of that cycle of, oh, I'm no longer hyped, I'm no longer happy, and I need to use it again, right? And then that's how behaviors and cycles start, and then you go in that circle. So we have to think about all of these things. A review of multiple studies and The NSDUH data estimated that 1.5% of people who are using benzos actually meet the criteria for benzo use disorder. Patients who use benzo are physically dependent on the medication and are physically dependent on the medication are far more common than patients who have benzo use disorders, right? So if you think about the statistic that we just talked about, 1.5% of people who use benzos, they meet the criteria for benzo use disorder. And if there are more people that are using benzos that have physical dependency than those that actually meet the criteria, think about that. So we have to be a little bit cautious about this. What is some of the terms that are important to know and understand? Tolerance is basically you're in this physiologic state where you need an increased dose of the drugs that you're using to have the same effect because your body's got used to it. And now when you use, like, let's say you take 2 milligrams of Ativan, now you're not feeling the effect anymore. And you need 3 milligrams of Ativan to feel the same effect you were feeling on 2 milligrams of Ativan. That's what tolerance is. Dependence, as we mentioned, this is a physiologic adaptation after you've repeatedly exposed yourself to that specific drug, right? And when you, let's say, decided, oh, you don't need this medication anymore, we think it may be contributing to your physical dependence, is giving you all these side effects or all these risks, well, let's taper you off. But then you start like a rapid dose reduction or you abruptly stop it, withdrawal symptoms can then start coming in. And this does not necessarily imply that someone is compulsively using it. It could just be a repeated use of the same dose they're on and they've developed dependence on it and they decided to stop and now they're having withdrawal symptoms. And these withdrawal symptoms, it's a very predictable syndrome of physical and psychological symptoms, right? That occur upon reduction or cessation of that dose. So it could be anxiety, it could be insomnia, people could have tremors, it can lead to seizures. So I have patients that will come in and it will talk about, are you having any withdrawals? Are you having any symptoms? And they'll be like, well, physically, no, but mentally I am, right? So then you have to think about what they're trying to tell you because you can have physical or psychological symptoms. And then, like we've mentioned already, substance use disorder, this is actually a maladaptive pattern. If you look at the DSM, every single disorder, in order to meet the criteria, it has to cause significant impairment. It has to cause some form of distress in your life. And for substance use, it has to be this significant impairment is mostly can be characterized by cravings, loss of control, continuous use despite the harms and consequences that are associated with your misuse, the tolerance and withdrawal that can come with it. And this is based on the DSM-5 TR, the most recent DSM. And the dependence may exist without substance use disorder, like we've mentioned, right? There are actually more people that are physically dependent on benzos than people that actually meet criteria for benzo use disorder, according to current studies and literature. So let's talk a little bit about some epidemiology, right? And patterns of use currently in the US. And this will give us a little bit of an idea why it's important to have these conversations. So remember we talked about the 20 million or so people in 2023 that were using benzos that are actually, some of them, it's getting dispensed to them for 2 months or more, a percentage of them. Well, in the US, about 5% of adults fill at least one benzo prescription in a given year. So if in the US, about 5% of adults fill at least one benzo prescription in a given year, and there's 340 million people in the US, that's at least 17 million of your neighbors, your friends, your family members, your colleagues at work, at least filling one benzo prescription in a given year. So you could see the amount of use, like a lot of people are using them. And long-term use is actually defined as use greater than 120 days. And we've seen this use in studies that it's more prevalent in older adults. And if you remember, we said older adults, more risk. As you get older, the more risk associated with using benzos. So It's important to have these conversations of how to safely prescribe, safely taper, to reduce the risk and harm associated with this. And co-prescribing with opioids is frequent and a dangerous combination. So you have people that would be using benzos and opioids together, and they're prescribed for them, right? They're on Ativan, they're also getting oxycodone for pain. You really have to be cautious and take into account a lot of different things, which is why we stress the importance of individualized treatment plans, because you have to look at the person, what other substances may they be using, or what other medications may be prescribed to them, what are their medical comorbidities, look at the genetics, the environment, the social determinants that could be actually affecting them, right? There's so many reasons and factors that go into why people may use or can't stop using, or why we can't safely taper them, all of those things. We have to be aware of that. A study published in JAMA found that discontinuation of benzos in long-term users was associated with a small absolute risk in increase of harm, right? And that included non-fatal overdose and suicide attempts. And basically what it means is be cautious when you are deprescribing. Be very cautious and follow the standard clinical guidelines that are out there, because this is evidence-based. And we know, because we've seen how it's worked with other people, we've tested them, it helps. So keep an eye on that. Then we've normalized benzo use, right? We've normalized it. Scalable, fast-acting, and too often long-term by default. Because imagine starting someone on a benzo and you had a goal, you had a plan of, we're gonna use it acutely, short-term. And then you're 1 month in, 2 months in, their SSRIs kicked in, but the person's like, this is really helping me. I'm really doing well. And sometimes it's hard to take them off. It's a hard bargain to bring people off of it. And then it becomes a long term, because this person's saying it's helping me. It helps. The 2023 figures and 2018 duration data has truly underscored this normalization. And older adults continue to receive benzos despite the AGSBS criteria that literally warns us to avoid using them. When is possible, avoid it. When is possible, avoid it. Because the evidence of harm in long-term use of benzos are associated with cognitive decline, memory impairment, slower processing speed. There's multiple studies out there that shows this, right? Increased risk of falls, accidents, sedation, and especially in older adults. And I know I'm reiterating myself. The studies have shown that you have to hear the same thing at least 6 to 7 times to retain 66% of it. Keep saying it. And beyond the short term, 2 to 4 weeks is not well supported by strong comparative efficacy data. And long-term benefits are tenuous, especially relative to how well SSRIs and psychotherapies work for people. Nearly everyone taking benzos longer than a month develops physical dependence, right? And that's physiological, not a moral failure or anything. It's just physiological. So the clinician's job is to reduce the harm and build safe exits. Whether or not it's a formal substance use disorder diagnosis applies, your job is a safe exit. Stopping abruptly, we know it's dangerous. Withdrawal can include anxiety, tremor, insomnia, in severe cases, seizures, hence the emphasis on gradual personalized tapers. Withdrawal phenomenon can occur after therapeutic use of 2 to 4 weeks. So just after 2 to 4 weeks, withdrawal can happen. And remember, we said the risk of dependence is higher after 2 months. So those are 2 things to keep in mind. After 2 months, your risk of physical dependence increases. After 2 to 4 weeks, withdrawal can set in. Whilst tapering protocols exist, the biggest gaps are actually in access, the continuity, and system support. Patients may drop out mid-taper. They lack psychological services, right? Or they hit coverage cliffs. You would be surprised how many times I get a call from a patient, I can't get my meds. Or the pharmacy calls, you need a prior authorization. Insurance is not going to cover. And I'm like, I have to call insurance to be like, A, B, C, D, E, why this person needs their medication. And this is just general. It's just not even benzo. This person has been using this medication for how many years now? And all of a sudden, they've been stable on this medication, but all of a sudden I have to prove why they need the medication. And these are all systematic barriers. We have to do better with the healthcare system. We have to set up systems and operations that are safe and cost effective, but it's also patient centered and it's helpful for the person we're caring for. This is not like capitalism, is all I'm going to say. Right? It's not for profit. We're here to care for people. So also, many guidelines rely on low quality evidence and clinical consensus rather than randomized trials. We have biological know-hows of how to taper more safely, but patients and clinicians are operated in fragmented systems. Limited CBT access, coverage gaps, short visit, ADNP pressure. How many times you have to eye stop someone? The science really is to go slow and support well. Give them the psychological supports they need. If they need cognitive behavioral therapy for insomnia, get them that, right? If they need cognitive behavioral therapy for their anxiety, make sure you're getting that support whilst you're tapering them, seeing them more frequently, right? So we're going slow and you're tapering, remember the 5 to 10% every 2 to 4 weeks. That's what is being recommended. So doing that slowly and supporting well. But we have a system that's often telling you to hurry up and good luck, get it done. So it can be tough for clinicians. From like the conceptualized perspective, a few frameworks are very useful. If you're a clinician, if you're a prescriber, these are some of the frameworks that can help you. Risk-benefit equilibrium. So really looking at the balance between continued benzo use exposure versus the risk introduced by tapering. So what's the risk when I keep someone on benzo and if I take them off? What's the risk? What's the benefit? Does the risk outweigh the benefit? Is the benefit outweighing the risk? Again, tailored approach, individualized plan per patient. You have to take all factors into account and weigh the risk and the benefit. And then what are the alternatives, right? Is there any alternatives that may be better, give them a therapeutic effect with a minimal risk? Why don't go with that? So that's one of the best frameworks. It's making sure you're looking at that risk-benefit equilibrium. And then making sure it's patient-centered shared decision-making. So it's not just the provider making the decision, right? But the patient is in the driver's seat and you're there with guidance, with your expertise. Because you have to think about it, the patient is also the expert of their own body, of what they're feeling. Because you're not in their body. You can't tell them what they're feeling, right? So you have to rely on what they're telling you and then use your expertise and knowledge as guidance and making sure that you're doing what's best for the patient, right? Part of our oath is to do no harm and make sure that the patient also has some autonomy, right? And it's a fine balance between all of these things that we have to do. So making sure that you're having that discussion with the person and you guys, you're educating them. Because for most patients, if you educate them, that shared decision making is a little bit easier, right? So you're integrating the person's preferences. You're looking at the symptom burden and the readiness to that planning. Because if someone is not ready, it's not going to happen. And then system ecology. So looking at that ecology of the systems and recognizing that individualized tapering is embedded in a fragmented care. There's insurance limitations like we've talked about. There's stigma. There's regulatory pressures. So knowing all of that and being able to work around it and support the person. And if you have to call the insurance and have a conversation with someone for prior authorization, yes. If it's the collaborative care with the therapist, to say, hey, I'm actually going to start tapering this. Do you think that this patient can have a little bit more frequent visits of therapy? Maybe it could be individualized therapy and group therapy. Okay, what do you think is best? So having that individualized but collaborative care planning and supportive services for the person is going to be very important. So Let's go through some of the top questions I hear from clinicians and communities. Where do I start to taper? And right now, the guidelines are saying, I've said this again, so this is going to be like the 4 time, right? You have 3 more times to retain it for 66% of the time. The recent Joint Clinical Guidelines point to 5 to 10% every 2 to 4 weeks. So that's where you start the taper. So if someone is on 1 milligram twice a day of Ativan or Klonopin, right? Where are you going to start? You're going to start 5 to 10% every 2 to 4 weeks. Then make sure you stay flexible and make room to pause when symptoms climb. So if you start tapering at 5%, in the first 2 weeks, symptoms are getting worse. Have that space to stop and assess. You don't have to continue tapering. And if you have to come back to the original dose of what they were on, then assess, monitor, and try again, that's also fine. Once you assess, you can figure out other ways that you can safely taper. But before you even begin the taper, make sure you have thoroughly assessed and come up with an individualized plan that is patient-centered. You've looked at the system psychology of all the barriers and the stigmas and everything that comes with that. And you've looked at the risk-benefit equilibrium, right? So if you've put all of these into practice and into your individualized plan, I think you're going to be in a safe space of you've safely put together a plan for this person and you're moving on. And if it didn't go as planned and symptoms come, it's okay to pause, to stop and see, because faster rarely ends faster. Because if you're tapering someone faster, it's more likely you're going to have to stop and restart, stop and restart, stop and restart, compared to if you go slow and you support well. That's the goal. I know the system is telling us faster and good luck, but as clinicians, as prescribers, what we're leaning towards is go slow and support well. Okay. So the second question I hear most often is, should I switch to a long-acting agent first? And for many people, you can do that. You can transition from short-acting agents to like diazepam or Klonopin for like these smoother curves for people, right? They have smoother transitions or smoother tapers. And the side effects or the withdrawals, the recurrence of their symptoms may not be as bad, but this must be individualized. Again, it's important that you're assessing the specific person and it's a targeted plan. You have to look at the comorbidities, their drug interaction. What is the patient's preference? And yes, it's good to look at patient's preference. And you are the other expert, on the other hand, guiding that. So you can have a conversation with this person and get a good plan, right? Get a safe plan. The principle is stability over speed. So again, we want to go slow and support well to give them stability, to give them therapeutic effects, not go faster and cause them all these symptoms and risk that may likely outweigh the benefits. So we want consistency, right? And this has been shown consistently across all these guidelines that are out there. Stability over speed, go slow, support well. And the other questions that sometimes may come up is, do adjuncts help? The evidence really shows that pharmacologic adjuncts, it's like a mixed batch, right? Some may help, some may not help. Non-pharmacologically, CBT helps. I've used CBT in personal experience for insomnia. So for those that would be taking like benzos for insomnia, and 65 and older, falls, cognitive declines, all of that. At this point, we've looked at all the factors and your risk outweighs the benefits. So let's try something else and see. Most of the times, personally, I will introduce like a CBTI Or if they're not in therapy, I refer them to therapy for anxiety before. So they get used to that and see how it helps before we start like a taper. Sleep hygiene is one that I do for everyone that I see. And I do encourage every single person to do that. 3 things that we will talk about is you see me, is we would talk about your sleep, we would talk about exercise, and we'll talk about healthy eating, right? And sometimes some of my people make fun of me, but I'm like, I am prescribing it for you. Just like you are getting all these other prescription, I'm prescribing 3 times a week, 20-minute walk. And then we're gonna go in graduations when you get comfortable with your 20 minutes 3 times a week. How about we make it 30 minutes 3 times a week? How about we add a little bit of moderate to vigorous physical activity in there? Okay, how about we add 1 plate of fruit into your diet every day? If it's someone that's having a little bit difficulty, how about let's do it every other day? We'll start there, 2 times a week. And then we go to 3 times a week, 4 times a week, right? We start slowly and we implement these things. How are you sleeping? Are you watching TV to go to sleep? A lot of people do. And they're like, well, I'm struggling to sleep. Well, the blue light is telling you to wake up. You're doing any and everything in your bed. Your body and your brain has associated all these different activities with your bed, including sleeping. So when it's there, it's not looking to just sleep, it's looking to do everything else too. Let's get some sleep hygiene in here. So these are things that I do with every single person that I see. And I think it's good practice to do that with everyone as well. So these are some non-pharmacological supports that can help, that have been shown consistently to improve the rates of being able to stop and for people to be able to cope with that tapering that people do. But even if they don't completely erase every symptom, they're going to help. They're going to help with the intensity of the symptoms. They're going to help with the duration of the symptoms when they happen. They're going to help with the frequency of that symptom, of how often you're getting these symptoms. And another question, isn't discontinuation itself risky? And what I would say to that is observational studies suggest like very small absolute risk increases in acute harm after discontinuation. And this has been shown mostly in long-term users, like people that have been using for a very long time and are stable, right? So this really underscores the need for a close follow-up. So if you have someone that's stable on their benzos, but you've done all your steps of individualized planning and you've come to the conclusion, okay, the risks are outweighing the benefits and it's better that we taper you off of it and you start to taper, remembering it's slow and we're supporting them well. There's that little increase of risk, but you can do close follow-ups and very flexible pacing and don't stop abruptly, right? Remember, we're going slow. It's not fast. We want stability over speed, so we go slow. And these practices should mitigate some of those risks that can be associated with it. And what are the predictive pitfalls is another question that comes up sometimes. So cutting too fast, that's the biggest pitfall. And if you haven't heard anything that I have said, you've probably heard me say, go slow, support well for the 5th or 6th time now, right? So cutting too fast, especially near the final 25 to 30% of the dose, it's actually really harder when you get to like the lower doses and the end of trying to taper. It gets a little bit harder to take people off or taper people. There are a lot of people that's, I got to 0.5 or I got to 1 and now I'm stuck here. So you see people that are on like 0.5 for years and you're like, why? Because they got to that final dose and it was really difficult to take them off, and keeping them on that dose was safer than discontinuing it at that point. So that's when you would do that. So failing to pause and reverse is also another thing. If people are having symptoms and their symptoms are recurrent and worsening, just stop, reverse the step, go back to the previous dose. Ignoring co-prescribed opioids or alcohol risk is another thing. Lack of therapy access, poor care coordination. You have to coordinate with all the providers. Documentation gaps that create fear and defensive rather than collaboration. So when you're documenting, making sure that you're documenting in a very safe way that's collaborative and it's not throwing another person under the bus and it's creating fear. So then now people are like, oh, I got to quickly taper someone off because so and so said ABC in their note. And it's making me look like I'm doing something wrong. So making sure it's not like that defensiveness when you're doing that. And it's actually collaboration because you're talking to everyone involved and you're collaborating with them. Let's do a case. This is Mr. R, 62, and he takes Klonopin, 0.5 in the morning and 1 at night for the past 5 years for panic and insomnia, for panic attack, not panic disorder, panic attacks and insomnia. He has these new symptoms of word finding issues, unsteadiness, and he drinks 2 glasses of wine nightly. His insurance is currently denying CBTI, and his psychiatric follow-ups are every 6 months. What is your clinical approach? What are you going to do? The first thing is to validate their fears. Reassure them. Validation goes really long way. Incorporate motivational interviewing into this. Find out what their fears are. Clarify the dependence versus use disorder. Safety first. So counsel them on the alcohol use, right? It puts them at an elevated overdose risk, especially if there's alcohol and opioid use. Plan to gradually taper them. Refer them to therapy, to a chemical dependence clinic. Make sure you're referring them to appropriate services that they may need. Remember, the goal is to go slow and support well. So all the services that they may need when you found out that alcohol use is in the midst of all of that, in addition to counseling them, refer them to the appropriate services, right? Appropriate support that they may need. Consider consolidating. He's on 0.5 in the morning and 1 at bedtime. So how about considering consolidating to 1 daily dose? You could do that. You could try but the recommendation is the 5 to 10% every 2 to 4 weeks. That should be the goal, the tapering goal. And then have that explicit option to pause, right? If symptoms reoccur, if they're having worsening of their symptoms, just pause, reverse, go back to the normal dose if you have to, and then try again. And anticipate that it's going to be very small doses. When you're getting to that last 25 to 30% of the dose left, you may have to go micro dosing. And if you need to use a compound liquid, if needed, do so. And then, again, added non-pharmacological supports that have been shown to help. So CBTI, because this person, it's saying that their insurance is declining CBTI. There's a lot of courses for clinicians and providers for CBTI that you can partake in and equip yourself with the tools to help your patient with CBTI. You, the clinician, can help with that. There's like CBTI workbooks, online programs. So if insurance denies, they can explore these other avenues as well. Sleep hygiene. So making sure you're talking to them about sleep hygiene and they're putting some of these things into practice. I believe the American Academy of Sleep, on their website, they actually have a sleep journal to track sleep, and that's probably one of the places I'll start from too as a provider if insurance is declining CBTI. And the first step of CBTI is to assess the person's sleep through sleep diaries and sleep journaling. So you can use that. For the first 2 weeks is go on the American Academy of Sleep's website, get the journal paper, send it to the patient, print it out for the patient. They can do that. There are also apps there. There's this one app that I actually use with a few of my patients. I'm blanking on the name of the app. CBTI Coach. I've used CBTI Coach with a few of my patients. And the only thing with the CBTI Coach when it comes to the sleep tracking, and even with some of the sleep journals, I've incorporated my own like little column of actually tracking like at baseline what someone's sleep routine is. So having the person journal or write down what their sleep routine is, and from day to day, looking at the changes that may have happened, right? Oh, I slept well today. What did I do differently today? When I look back at what my routine has been, that may have influenced how I slept well today. I didn't sleep good today. What had changed, or what factors? Were there any precipitators? Were there any triggers that made me not sleep well? So looking at all these can help as well. And of course, considering antidepressants. So SSRIs, SNRIs, if indicated for the panic disorder, these have been shown to be effective for them. And close follow-up, it could be weekly, bi-weekly, then space it out based on how the person is doing. And looking from a system lens. So one thing I'll do is call an insurance. If you're having trouble, I will call up the insurance. And I'm like, okay, let me find the number. I will call them and ask them what's going on. Like, why? Is there anything that I can do? One of the episodes coming up, one of the lessons from that episode and from the guest is just the power that you have as a clinician. Sometimes we don't realize that we have the power to make change in certain arenas. They had shared a story of how they had helped one of their patients get a warrant vacated because that warrant was interfering with their care. And all they did was write an appeal letter to the judge explaining how their mental health, substance use, and social determinants affects the patient as a whole, and what it would mean for that warrant to be vacated. We have the power, and you can use that power. So call up the insurance, appeal for the CBTI for Mr. R. Why is it being declined? And then when you find out the reason, is there anything I can do to reappeal this? Explore tele-CBT, group-based sessions. And all of that is important when you're collaborating with a therapist, right? When you're collaborating with the team, because they can have all these resources that you may be unaware of, and they can help you connect your patient or your person to these resources. Community centers like YMCAs. I just recently, one of my people that we've been talking about making like med adjustments because they're like, I have no motivation. I have no, and every time we talk and we're like going and discussing, why do you not have no motivation? Like, let's find out the why before we start making all these med changes. Why? I'm sitting at home all day. I have nothing to do. Is that really that you don't have any motivation, or you're just home all day and you don't really have much to do? So you go bored. Guess where I send them to? YMCA. They have activities there. You know how I learned all the activities that are YMCA is through another person that I care for. And this person is like, I am 80. I wake up in the morning, I go to YMCA because they have an aerobic exercise class, and I do that. I go to the library and I take the photography course, and they're doing all these activities. But through that person and through just talking to them, I learned all these activities that are in the area that I can send other people to as well. And some of these they're free, and it can get someone out of their home. It can give them the motivation. They can have a social life, and I don't have to add another medication. So use the community resources that you have and coordinate with primary care to address falls, PT referrals, home safety, like if there's like carpets and all these things that can increase the risk of falls and all of that, making sure you're coordinating all those cares. And with pharmacy for compound and lower strength doses, if it's needed, you could do that as well. And document the rationale to reduce stigma. So if you're deprescribing, making sure that everyone that's involved knows that this is safety focused and it's not punitive. It's not because someone is misusing or doing any of that. Try to reduce that stigma. So your documentation should be safety focused. We've talked about a lot of different things. We've talked a lot about how we can safely deprescribe benzos or taper people off of benzos, and just all the lessons that we have learned. So if you're a clinician or you're a trainee, meaning you are a doctor in training, a clinician in training, these are some of the thoughts I want to leave you with. So think about it. Everything that we spoke on, when you're starting to taper, which symptoms make me pause? how would you handle an end taper hypersensitivity? Like, I know we're saying 5 to 10% cuts, but is it going to be a time where you're doing 1 to 2%? Because you're at the last 20 to 30% of the dose, and it's very difficult. Or if you remember the example of the people that I gave that are at some point, you're able to taper them, but at 0.5, 0.25, it's very difficult. So you just leave them at that. I have someone that's on 0.125, and you leave them at that because at that point, the risk of tapering outweighs the benefits. It's safer to keep them on the 0.125. You keep them on the 125. And for someone like Mr. R, what would be your plan if there's alcohol use and that alcohol use it's increasing during the taper? Think about some of the resources and the strategies that we've discussed. And if you are a policymaker, I want you to think, what are some coverage changes that we can make that can help? You've listened to all of this to this point. If you got anything out of it, I want you to start thinking as a policymaker, as a change maker. What are some coverage changes that you can make in your position that will prevent system barriers, that will prevent patient drop-offs, that will prevent coverage cliffs when someone is getting tapered? How can the whole PDMP system and quality matrix be adjusted to support and not punish, and to lean towards safer tapering? What public messaging reduces stigma and promotes informed consent for long-term benzo use? If you're a part of the general public, listen to this. I want you to think about how you interact with people that you believe may have substance use, the language you use around them. For instance, calling someone an addict. They're not an addict. They have a name, right? They have a substance use disorder, just like someone may have diabetes, just like someone may have hypertension. They have a medical diagnosis, right? Don't identify people by their problems. Identify them by their names, by who they are. They're not defined by their problems. They have a whole life, a whole person to them outside of that specific problem, that substance misuse. So make sure that you keep it in mind how you address people and how you interact with people. In closing, remember, we're starting slow, 5 to 10% every 2 to 4 weeks. We're planning for micro reductions at the end, and we're building non-pharmacologic scaffolding from day one, even before you start tapering. And yes, the system is telling you go faster and good luck, but we're sticking to go slow and support well. If you are a student, I want you to master the difference between dependence and a substance use disorder. Master the difference between all these different terms, withdrawal, tolerance, and what they mean for the people that you're interacting with during your clinical rotations, during your sub-Is, all of that. And the role that you can play in making their stay in the hospital, their visit to a clinic, more positive. Because tapering is a clinical skill, and it's also a systems skill. And it takes everyone. It takes all of us to make a difference. And if you're a policymaker, fund integrated pathways. Please fund collaborative care models, coverage for CBT during tapers, pharmacist involvement, compounding access, protected time for follow-up. Please fund these, fund research. We need more studies. And maybe let's think about what the types of research were funded and the representation of that research. Who are the people that are more affected? Are they represented? At the end of this research, is it going to be generalizable? Let's think about all of these things. And if you are part of the general community listening to this, you are taking a benzo, a family member taking a benzo, please don't ever abruptly stop your medication. Even if it's not a benzo, don't abruptly ever stop your medication without talking to your clinician first. I know there's so many resources out there. You can go on Google and you Google how to taper a medication or how to get off medication, and it will tell you, ChatGPT will tell you. There's so many resources. But always remember, these people can make mistakes as well. ChatGPT hallucinates and makes mistakes, right? That you have to make sure that the information you're getting from the internet is from a reputable source. It's good and quality information that you're getting, because you don't want to put yourself at risk. And just talk to whoever is prescribing it for you, right? And if, in cases where no one is prescribing it for you, but you have your hands on it, find someone, a clinician that you can talk to. It could be a primary care provider they feel like they need to refer you to someone else. They can refer you to someone that can help. Talk to a clinician before. Remember, we've spoken so much about personalized plans and supports and all of that. They will help you secure those supports and use those strategies. We can't taper fear, but we can replace it with information. We can replace fear with partnership. We can replace fear with time, and we can replace fear with collaboration. So please, 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 I hope you're able to take at least one thing from today's episode. On the next episode, we're actually going to delve deeper into the Joint Clinical Practice Guidelines on benzo tapering that came out in June of 2025. I know it's 2025. I'm blanking out in a month, but we're going to delve deeper into it and in trying to summarize the actual recommendations of what they're given for special populations, all of those things we're going to talk about. Because I know y'all are not reading all of it. So we'll break it down as much as we can. And then we are also encouraging to actually go read it. Go read it. Thank you so much for joining us on the Transformed Mind podcast. It's always a pleasure having you all. Until next time, stay ready, stay aware, stay grounded.